everyone. Thanks for joining me today. This is our new product webinar for the month of July, and we want to go over some really cool things. We'll get straight to it. For those who just want a general outline of what we'll be covering, the very first thing we want to talk about is a product called enkephalin. I'll go into it. The typical indications for everyone though are going to be generally cancer treatment, number one, but maybe even some alternatives to LDN. So just something to definitely consider as a product. And then we'll be going also into the cosmetic products. We've had a lot of success with our GHK copper. This is one that we've had now for a couple months and are experiencing really, really good results across the board as a cosmetic peptide. And even beyond that, a peptide for reducing stress, mitigating cancer risk, and just helping with repair and recovery. So we'll be adding some addendums to that, some of the other really popular cosmetic peptides, which we'll now start to unroll. So with that, I'd just love to get to it and start with a little bit of background information about the opioid growth factor receptor and these endogenous opioid peptides. The one that we're going to be looking at is called enkephalin, and actually this was discovered in 1975, along with a lot of other, I should say, opioid peptides, short-chain opioid peptides, which are endogenous signalers. And so this one in particular, the enkephalin, was one that stuck out, at least initially, because it behaved a little bit differently than most, and definitely showed that we need to look into more of these endogenous receptors a little bit more. And at this point, obviously in 1975, most synthetic opioids to treat pain were already pretty well identified. So this one was looked at a little bit differently, and for really good reason. So in neural tissues, we know that the enkephalin has considerable selectivity for the delta opioid receptor, and to a small extent, the mu opioid receptor. Whenever we talk about the enkephalin, its use in cancer as an alternative to LDN, this is probably the number one question we always get is, hey, is it going to be addictive? Is it going to treat pain? And the answer is to a very, very low degree, it could be addictive, and to a very, very low degree, it can treat pain. Due to its effect on the delta opioid receptor and the mu opioid receptor, it's going to have less of an effect than most synthetic opioids. The effect that this is generally made to induce in the body is actually to stop growth, which is why it's effective in cancer. And so while it might simulate some pain relief, it's not going to be very, very significant. The other really cool thing to mention here is that they found that products that stimulate the delta opioid receptor with a little bit more than the mu actually can prevent respiratory depression. And so this might be a strategy sometime in the near future to mix with most other opioid products so that you don't get the respiratory depression and death as a result of overdose. And so the function of this is it's got receptors in every tissue, but whenever this was discovered, they didn't even know where it was working. They obviously knew it was working on the delta opioid receptor and the mu opioid receptor, but beyond that, they saw that its tissue expression was not like most opioid receptor products. And so they examined it a little bit further and found that it was really related to the opioid growth receptor and entirely created endogenously to modulate growth. And so what this does is this peptide is actually targeted to cellular proliferation. It delays the G phases of a cell, but also affects cell migration, differentiation, survival. All in all, it can show that essentially it can stop these cells from replicating and provide significant retardations in growth, which is exactly what we'd want for cancer. And this is sort of the mechanism. I put it on here to show that it's not an effect made by the delta or mu stimulation. This effect on growth is mitigated entirely via its translocation as a complex with the opioid growth factor receptor to the nucleus, where it's modulating that DNA independently and suppressing some types of growth. Whenever we get down to it, the enkephalin is really at this point used for cancer. And the reason it's used for cancer is, in addition to stopping growth, it also has a significant effect on the immune system. And you know, for those people who are specialized in trained with using low dose naltrexone, they'll tell you that it also affects the immune system. So this is a really, really cool study where we see that it affects most types of immune cells. It affects the interaction between dendritic cells, CD4 T helper cells, and even CD8 cytotoxic killer cells. And so what we see in cellular studies and in vivo studies across species is that we see things like the thymosin alpha-1, where the immune system is upregulated and able to fight those cancer cells a little bit better. So you get immune system clearance as well as slowed proliferation of cancer cells. And in 5 different cancer cell studies treatment, metenkephalin has also shown to reduce tumor cell resistance, and in vivo, it's almost always results in increased survival. And so just going on to a little bit, this is another human trial, which we saw that helped by decreasing T regulatory cells. For those of you who know, you know, T regulatory cells can sometimes be a detriment to the immune system fighting T regulatory cells are made for autoimmune disease. So to make sure that we all don't attack you know, everything and every you know, peptide in our body. And so this, by eliminating inhibiting T regulatory cells, actually increased the amount of CD4, CD8, and other natural killer cells and T cells and dendritic cells in order to maintain an optimal immune response. And so as a result, you know, the metenkephalin works as a strong immune booster with a great potential in restoring the immune system in cancer patients. But even beyond that, it could be a great chemotherapy additive, which could sustain the immune system of cancer patients in order to maximize the result. And so what we're seeing is, you know, better results, increased survival, and a strengthened immune system in a relatively, in some cases, weak immune state. And so this one is it's got certain types of cancers where it's definitely better. And actually, these cancers can also have genetic changes, which essentially stop producing the opioid growth factor receptor. So they lose that input for growth retardation, which is why that upregulating this, it can be so important. This phase 1 human clinical trial that I'll go into showed really great results in severe pancreatic cancer. Again, a very, very small sample size, but compared to the standard 5 FU in chemo combination, we saw much improved results. We saw better pain control, no adverse hematologic or chemistry markers, and quality of life metrics in terms of subjective metrics also improved. This is the study which I'll be sending out afterwards. I'll be sending out every study that's been published on the metenkephalin, as well as it's broken down by its results in human literature. So what we saw is that this one had a 53% positive clinical response compared to 23% with the other combination. And it improved survival by 62%. So a significant benefit with really very, very few downsides. Again, we always worry about the addictive nature of some of these opioid stimulators, but as I talked about earlier, due to its effect, very, very small effect on the mu receptor, we're not getting a ton of addictive behavior. And we'll talk a little bit more about the dosing of this in some of these cancer patients. But the reason we started offering this and want to offer this to our patients is because it's a great supportive therapy. Like the thymosin alpha-1, like the IRGD, the metenkephalin can help in traditional cancers, just in cancer treatment as a supportive therapy without interacting with things like chemo or radiation or anything of that nature. So definitely one to consider. This is what I was referencing earlier, where the presence interaction of the opioid growth factor, which is also synonymous with metenkephalin, and the opioid growth factor receptor have been shown to occur in a variety of places, but in particular head and neck cancers, the triple negative breast cancers, those are going to be the ones where it has the most impact. And so, but even beyond cancer, it has a lot of impact in a variety of cell tissues. One of the biggest things that we see is it can really stop the progression of MS. We see reduction of a lot of the cytokines. And with the MS being an autoimmune disease, this makes a little bit of sense, right? We talk about using the low-dose naltrexone oftentimes for MS or different types of autoimmune disease. And this is actually happening in a similar mechanism. So something to consider in the MS protocols, which typically will use the thymosin alpha-1 as well for that immune change. We'll also use things like the GHK copper, which we'll talk about a little bit later. And we'll also use things like the cerebrolysin to help repair that myelin in MS patients. And so definitely something to keep in mind for your MS conversations. I want to talk about its implications with LDN, just because LDN is such a popular therapy in the integrative space. And for those of you not familiar with LDN, the low-dose naltrexone, when given at low doses, can actually normalize the immune response and increase the endogenous production of endorphins and enkephalins. And actually, the number one enkephalin that it will actually upregulate is the metenkephalin. And so it's actually, this is again the same pathway. The reason you do the low doses of naltrexone is because it's not seen at the higher doses. You don't get the same immune response. You don't get the same increase endorphin and enkephalin response. And so, but together, the enkephalins can actually just, as an exogenous product, also do the same thing. And so, we want to think about these hand in hand, but it also gives us a lot of different treatment strategies beyond cancer. You can think about the metenkephalin for, gastrointestinal diseases like ulcerative colitis, IBD, Lyme, cirrhosis, and any of the autoimmune neurodegenerative conditions. And so another something to think about. I can tell you that in our experience, we've really only done this anecdotally with ulcerative colitis patients and cancer patients. And in particular, we have one physician who's I think definitely leading the way on the cancer research, and has some really good lectures out there. So if any of you are wanting to learn more about this particular product, please let me know, and I'll connect you with that physician. Just sort of going forward, the dosage of this is actually relatively easy, because it's going to be essentially one administration a week of 10 milligrams in an IV. We usually the max dose used in the clinical trials are going to be 250 micrograms per kilogram. So you can go relatively high, but in our experience and what we've done with the cancer patients to date has just been 10 milligrams once weekly as an IV. We've been getting some pretty great results. And so I know a lot of you all don't treat cancer, but as a supportive therapy to cancer, the thymosin alpha and this look extremely promising. And I'm sure you'll be hearing a lot more about this as it continues to get phase 2 and phase 3 clinical trials. And with the Right to Try Act, this is definitely something to keep in your back pocket for those patients who have little to no hope, those patients like we saw in the pancreatic study. And so with that, I'll definitely open up to questions at the end. But for now, I want to go on to some of the cosmetic peptides. The cosmetic peptides have been relatively popular for us ever since we came up with the GHK copper. So just to talk first, I want to talk about a little bit just about the basics of skin, right? The three layers: the epidermis, dermis, and subcutaneous tissue, with the dermis being the deepest layer and where we actually find all of the important fibers that sort of decrease with aging. In particular, collagen and elastin. 80% of the dry weight of their skin is actually collagen, and that significantly decreases over age. And 5% of those are elastin, which is also very, very important. And then the rest is sort of the dermal connective tissue with the glycoaminoglycans, such as hyaluronic acid and some other products. And so you often hear those terms, and those are all declining with age. And so just to go over the collagen more in particularly, because it's so important, it makes up the majority of your skin. The dominant type found in human skin is type 1, followed by type 3, and lastly type 2. The type 2 collagen is mostly in your hyaluronic type collagen in your knee joints and things of that nature. And collagen is synthesized by fibroblasts, and then it undergoes some post-translational modifications in order to ensure stability and tensile strength. And whenever we look at us under a microscope, old skin versus new, youthful young skin looks very, very different. Whenever you have this young skin, you see thin, wavy, uniform units, where whenever you get older, you see thickened, clump, basophilic, collagenous material, which stains really, really blue. And I don't have a lot of histology slides in this presentation, but in a lot of the things that I'll be sending out, you can see some of this histology and how a lot of these cosmetic peptides affect it. The other big thing that we just want to talk about is the elastin. And elastin, again, is a product of fibroblasts, just like collagen, but it is more of the rubbery tissue, which can be stretched and causes sort of the bounce in the skin. And it's also something we want to target with a lot of the therapeutic molecules we choose to combine. So with that being said, most of the skin peptides typically revolve in four traditional categories. Starting from the right to the left, the carrier peptides deliver trace elements like copper and manganese that are necessary for wound healing and processes. And the best example of this is, as most people are familiar with, is the GHK copper. For those of you who aren't familiar with GHK copper, the GHK copper sort of acts as a delivering copper to the DNA and can yield a host of benefits from a repair and remodeling perspective. It increases collagen synthesis, can increase collagen levels in skin by around 70%. Reduced wrinkles by 35% and has been shown to be better than retinoic acid and vitamin C. And beyond that, just due to its effect on a genetic level, it can also help with tissue remodeling and things like ACL reconstructions. And so it's a really, really interesting product that has a lot of genetic implications. And that would technically be considered a carrier peptide due to some of those trace metals. The other two, I'll go then to the signaling peptides. The signaling peptides are going to be peptides which trigger a signaling cascade and particularly work to the proliferation of collagen, elastin, and glycoaminoglycans like hyaluronic acid. There are hosts of these signaling peptides, but they're usually so specific in their particular, what they're encouraging, that they tend not to be as useful just because they're very, very narrow in spectrum, whereas the carrier peptides can have a much broader effect. Same with the enzymatic peptides. They're not necessarily there yet. They might affect things like the T-TAT superoxidase dismutase. They might stimulate hyaluronase, but honestly, they're so narrow in spectrum that a lot of people aren't using them, which leaves us just with the carrier peptides and then the Botox-like peptides. And the Botox-like peptides are the cosmeceutical peptides which relax muscle just like Botox, right? And we'll talk about some of those mechanisms of actions and why pairing these together would be good for your patients and offer you a good therapeutic strategy in your office. So the first one we want to talk about, well, again, just going over as a class, Botox works by decreasing the amount of muscle activity and inhibiting the fusion of the acetylcholine vesicles to the cell membrane, which basically makes that muscle inactive. And we're doing the same thing. So this is a quick picture of the Botox mechanism of action and where Botox is working. On the left, you see the normal process of acetylcholine release when the vesicle fuses. Botox makes sure that SNAP25 cannot be sort of cleaved off, and as a result, the vesicle can't fuse. We're going to be mimicking that same biology with a lot of these cosmetic peptides. And so argireline is by far one of the most common. It's been around 18 years now, and it's a very short peptide. It's non-toxic, but it stimulates, or it acts a lot like that botulism toxin, and it interferes with the SNAP complex in a very, very similar way. This one has been well studied and well documented. And unfortunately, I think that a lot of people have made claims to this product's efficacy, and it's actually not what's in the product. And so just to give an idea, in a very, very short time, just 4 weeks, you can see a 48% improvement in fine lines and wrinkles in the eye area. Here are just some examples of some of the creases that you can actually see. On the left being the before, and on the right being after. You can see significant decreased depth in a lot of those wrinkles, and the top is the dry skin, and on the bottom is the oily skin. So you can get an idea of how it works in both. Just as another instance of a clinical study, they showed that just at a 10% concentration, it reduced the depth of wrinkles 30% after 30 days. So you're going to be somewhere in that 30 to 45% decrease in wrinkle range with just this product alone. Another product that you often hear about, and I want to mention, is the Snap 8. This is not one that we're offering as of yet. It doesn't have a whole lot of clinical data. It's a trademarked product, but whenever you bring up the Botox-like peptides, this is definitely one that needs to be talked about. And it works in a very, very similar way, but it's been claimed to have a better effect than argireline with a similar mechanism of action. So they're saying that they can decrease wrinkle depth by up to 63%. I don't know that we've seen that as much in our experience, and we might be offering it here shortly, but I think that right now the argireline is definitely the way to go if you're looking for that more Botox-like appearance and effect. The next one on the list is another Botox-like peptide called Faisal. This is usually goes hand in hand with the argireline, just because it also works as a Botox-like peptide, but it works in a different way. What this does is that it acts as an enkephalin product and binds to the enkephalins in this synapse junction, and reduces the calcium release, which then reduces the ability for the vesicle to be secreted and then yield its effect on the neuromuscular junction. And so this is important because it doesn't target that SNAP complex. It targets a little bit further up in the process. And so we know that stacking some of these things, particularly in the peptide world, stacking things with a similar mechanism of action, but in different receptors is always positive. And we see the same thing with the combination of the Lufazil and argireline. What we see is that together they had a complementary effect, and we almost always recommend them to be used together. And so again, this goes over some of the results of the cream together. This was a twice daily application, and we